Our previous speakers were introduced by non-directed kidney donors who serve on the advisory board of the National Kidney Donation Organization.
And you won't be surprised, Ned, but our next speaker is also introduced by a member of the NKDO team. But Jen Benson is a little different from the others you've already met. Her perspective is that of someone who is a kidney and pancreas transplant recipient.
I'm pleased to announce Dr. David Serur joining us today, formerly from Weill Cornell, New York Presbyterian, now with Hackensack Meridian Health. He is a phenomenal nephrologist with over 20+ years of experience. He's excellent, fully devoted to his patients. His experience speaks volumes of his expertise. He is absolutely committed to his patients and his staff. Please welcome Dr. David Serur.
I'd like to talk about chronic kidney disease as it pertains to people who are on dialysis or who are looking to eventually get a kidney transplant. So let's go through some interesting illustrative slides. Chronic kidney disease are patients that have a wide gamut of presentations. They can have a 50% kidney function, they can have a 0% kidney function. By and large, patients that require a kidney transplant or require dialysis have stage 4 or stage 5 kidney disease. As you can see in the slides here, the higher the stage, the worse it is. And different things cause kidney disease in the United States. Most of them are diabetes and hypertension. There are other diseases as well, like polycystic kidney disease. But it would be fantastic if we were able to prevent diabetes, prevent high blood pressure, heart disease, obesity, and smoking. By doing those, you can probably prevent 70% of all diseases that we know in the United States. So that's a goal, prevention of CKD. It's been shown that CKD education clinics are very effective in getting patients into treatment. Such clinics exist in the United States. They result in people not having to crash into the ER with end-stage renal disease, but they are educated early, they are referred to transplant early, they are referred to nephrologists and to fistulas creation early. And the prevalence of ESRD is growing. The number of patients on dialysis is growing, probably because there's a lot of diabetes, there's a lot of obesity, there's a lot of hypertension, but also patients are living longer. There's good primary care in the country, and patients live longer than they ever did, and it's more time for damage to occur to their kidneys. And the treatment in terms of dialysis and different modalities of dialysis is also, of course, growing. But the number of transplants has not really grown. The number of home hemodialysis is going up. The number of peritoneal dialysis, which is also at home, is going up. But transplant has been a little bit flat over the years, but recently has been improving as well. So when someone does have chronic kidney disease, most of them usually go on dialysis first, as the availability of transplant is not there for everyone. So a dialysis machine sort of looks like this, and the main part of the dialysis machine is not the big stand-up machine that you see, but that little filter on the upper left-hand corner. That's the artificial kidney. So blood comes from the patient, goes into the kidney, into the artificial kidney, and water goes in the opposite direction through that same cartridge, thereby cleaning the blood. And the clean blood then returns to the patient. This takes about 3 to 4 hours for each session, and about 120 liters of water are used in this session. So a good water supply, clean water supply, is needed. There are the usual dialysis is one where you go 3 times a week, and you stay in the dialysis unit, or you can even do it at home 3 times a week. And as you can see in that method, the shifts in water and waste does go up and down like a jagged pyramid, as you can see in the illustration. Nocturnal hemodialysis is one where you do it almost every night, if not every night, and it's done for many hours, so that the shift between Monday and Tuesday and Wednesday and Thursday and so on is much less than what it is when you have the intermittent 3-day-a-week dialysis. So this is an advantage of nocturnal hemodialysis. And as you can see from the slide here, hemodialysis can be done at home, in your backyard sometimes. I'm not sure where this guy is, but he's got it all figured out. He's probably sitting by the pool. He's got his dialysis machine right next to him, and he seems to be doing well and is a happy guy. Not everybody like this looks like this on dialysis. This is one of the exceptions, but doing it at home is a pretty good option. The other option for patients at home for dialysis is peritoneal dialysis. And peritoneal dialysis is sort of like what you see in the illustration. Water goes into the belly, water sits in the belly for several hours, and then is removed from the belly by that same yellow catheter that you see. The water that goes in is kind of clean without any impurities in it, and when it comes out, it has a lot of BUN and creatinine and potassium and other things that normal kidneys get rid of. And this is done several times a day by the patient. It can take 30 minutes each time to do it, 4 times a day, or a patient can do it while they're sleeping. And as you can see here, the same apparatus is there, except that a machine puts the water in and takes the water out. And this happens several times overnight. The patient, sort of from the inside out, clean water again goes into the peritoneal cavity, and then dirty water, quote unquote, comes out. And the patient then gets up in the morning and goes and does the usual things he does all day without having to think about the peritoneal dialysis. Of course, that's not the ideal, those are not the ideal treatments. There are better treatments, such as kidney transplant. And kidney transplant is the ideal treatment for somebody with CKD or somebody with end-stage renal disease, which is on dialysis, because the expected remaining lifetime of a transplant patient is much better than someone who stays on dialysis. As you can see in this graph, the upper blue section is the U.S. population in general. The lower red section is the dialysis patient population. Then the green section is the transplant patient. And what you see is that, for instance, if you are 40 years old and you get on dialysis, you have less than 10 years left to live, statistically, some more, some less, based on this graph. If you are a transplant patient, however, there's about 25 years left to live. So transplantation is certainly a much better modality than dialysis, certainly in the lifetime, in the expected lifetime. Also, of course, the quality of the life is much better with a transplant than it is on dialysis. When someone gets a transplant, a third kidney is placed into that body. The 2 other kidneys are diseased and they're usually not touched. They stay where they are, but a third one is placed in the lower abdomen as pictured here, and that's either from a deceased donor kidney or from a live kidney. About 2/3 of kidneys in the United States are deceased donor, and about 1/3 are from live donors. And the live donor can be a brother, a spouse, a parent, a child, a friend, a cousin, a complete stranger. The medications now are so good that a good match is no longer required. Transplantation began in 1954 on a regular basis, and in those days you had to have an identical twin to have a successful kidney transplant, as you see in the black and white picture to your left. One twin gave to the other, and the twin that donated the kidney is seen again on the right 50 years later with the transplant surgeon who put the kidney in. So donating a kidney certainly does not decrease your length of life, as you can tell from the 2 pictures, and does not hamper your life in a significant way. Nowadays, it's the same process. There is just like the doctors in the background there, there's a urologist, a transplant surgeon, and a nephrologist involved in kidney transplantation. When we evaluate living donors, those that want to donate a kidney to a loved one or to a friend, we do a full physical examination. We do a lot of testing, different blood tests, chest x-ray, EKG, CAT scan, 24-hour urine collections. We want to make sure that the donor is a healthy individual with low risk for him or herself down the line in terms of kidney disease. We don't want any donors suffering from kidney disease 20 years after donation, and by and large that does not happen. But the workup is complete. And we want to make sure the donor is screened appropriately for cancer, cervical, breast, prostate, colon, and skin cancer, to make sure that there's no malignancies that they have or that they might transmit to the recipient. And nowadays, the donation process is easier than it used to be. The surgery is laparoscopic in 99% of all centers. As you can tell here, there are a few small incisions and one larger incision. And even beyond laparoscopic, there's single port laparoscopic, which you can see here leaves a very nice cosmetic result with one scar as opposed to several small scars. And this works just as well in, as the older version of the laparoscopic surgery. How safe is it for a donor to donate a kidney? Will they die from donation in the hospital? The answer is no. The donor mortality for the inpatient stay is 0.007% chance of death, which is very, very low. To compare it to some of the more popular operations, like an appendectomy, it's 0.2%, and a cholecystectomy is 0.4%. So this is 0.007%. Thankfully, it's a very small number, hardly ever happens. And part of the reason is, even though it's major surgery, is because the donor is a healthy person. They have been ruled out from major diseases, and their risk for surgery is low. So that's why donor surgery is amongst the safest surgeries that there are. And beyond having a great low mortality, there's also a relatively low complication rate, though it's not zero. According to this study of hundreds of about 1,000 patients, 3% did have major complications from the surgery. 97% did not, but 3% did have complications. Some of those 3% required reoperations or ICU stay or something like that. While donor deaths is close to zero, donor complications is about 3%. Looking more long-term at the kidney function of that person who donated a kidney, it's great. This is a study looking at 25 years post-donation, and the GFR, the percent kidney function, and the level of protein in the urine is very good for 25 years hence. Similarly, this study showed the same thing. This is a 9-year follow-up showing that the GFR, the kidney function of the donors, is solid after 9 years. And of course, the other study was 25 years, but still showed the same idea. And just a summary slide of comparing donors to healthy non-donors, also looking at the function of their kidneys. And as you can see, 10-year study, the donors are doing very well. We are careful that our donors don't have excessive hypertension. You might be able to donate if you have mild hypertension, one that is perhaps controlled with one medication or two medications sometimes, but the worse the high blood pressure, the more chronic kidney disease that can happen. So we're very careful about donors not donating if they have serious hypertension. Also, if a donor is obese, we would prefer for that donor to lose weight and to stay at a lower weight after donation, because donors do have a higher risk of chronic kidney disease years down the line. So we're careful about that as well. And if a donor has had a history of kidney stones, we're also very careful about what kind of kidney stones and how often it happened and when it happened, so that there will not be a recurrence of those stones. Stones can recur 40 to 50% of the time, so we want to make sure that our donor is low risk for that. Also, if there is a family history of diabetes, we want the donor to be aware of that and tell us about it. So for instance, you have a 1 in 7 chance of getting diabetes if one of your parents had it before the age of 50. 1 in 13 chance if one of your parents was diagnosed after the age of 50, and a 1 in 2 chance, 50%, if both your parents have diabetes. So this is something, family history is something that is very important in terms of donation. If a female wants to donate a kidney, that's okay to do. If she is planning to have more babies after donation, that's also okay, but she has to know that there is a risk in terms of gestational hypertension, which is high blood pressure, such as preeclampsia, after donation. It's higher, it's 11% versus 5%. The baby, however, is not is the same and not in any way negatively affected by the woman having one kidney. So the fetal part is fine, but the mother may have more gestational hypertension after donating a kidney. In terms of the overall risk of end-stage renal disease for donors, it's relatively low. If you look at this this representation here, the donor end-stage renal disease lifetime risk is about 0.9%. I rounded off to about 1% when I talk to donors. If you are someone who will stay with the 2 kidneys and not donate, and you're just as healthy as the donor, that is a lower risk, 0.14%. So there is a little bit of a price to pay for a donation. It is better to have 2 kidneys than 1, but if you look at the absolute numbers, the absolute risk, it's about 1% lifetime risk of end-stage renal disease, and lower than that if you do not donate. In comparison, the general population that is not screened as well as donors are screened, they're not as healthy, so that's a 3% or 3.2% lifetime risk of ESRD. So within live kidney donation, sometimes a donor is not compatible with their recipient, so we do kidney paired donation. And we do that for someone that has a blood test that is not compatible, blood type that is not compatible with a donor, such as ABO incompatibility, or if the cross-match is positive between donor and recipient, that is, the mixing of the blood between the two causes the recipient white cells to fight against the recipient blood to fight against the donor white cells. That's called a cross-match positive. Or if a donor, if a recipient wants a better matched, younger, larger kidney, they may want kidney pair donation. Kidney pair donation, some people call it kidney swaps or kidney exchanges, where you sort of exchange a kidney between another donor-recipient pair that don't match each other and do match your donor and recipient. So that's where kidney pair donation comes in, and it's accounting for about 10 to 15% of all live donations in the United States. It sort of looks like this. It can start as a easy 2-pair exchange in the purple there, or a 3-pair exchange, as you can see, or more commonly a larger exchange, a larger cluster of patients. As you see a chain of donations and transplants on the right side, an altruistic, a Good Samaritan donor donates a kidney to a recipient, and then that recipient's donor goes ahead and donates to another recipient, and so on down the line. There's a whole trigger cascade effect of donations and transplantations, to the point where there could be a lot of kidneys flying across the country, as depicted in this graph here. It's safe, it's done, and the kidneys work as soon as they land. In addition to kidney pair donation, there's also simultaneous kidney pancreas transplantation. In kidney pancreas transplantation, both a kidney and a pancreas are placed in order to get the diabetic off dialysis. That's the ideal situation, usually in type 1 diabetics. In the last 5 to 10 years, there's been great strides in genetic instrumentation, genetic implementation to sort of make the pig kidney appear more human-like. And transgenic techniques are used and knockout techniques are used. I won't belabor the details of it right now, but it's come to the point where a kidney from a pig can go into a monkey, and it can stay there for up to a year with heavy immunosuppression. That is certainly an advance from just years back when it only lasted for a week or a month at most. And now these xenotransplants can last a year and more. Thank you very much for your attention, and we'll have an opportunity to ask questions and hopefully to answer them.
And I also want to mention that sponsored organizations are playing a critical role in the success of this Volunteer Living Donor Advocacy Conference. And in that context, I'd like to highlight the valuable guidance and support we have received from CareDx, your partner in transplant care.
Hello, my name is Peter Mark, and I would like to tell you more about CareDx. CareDx is proud to be the presenting sponsor of the National Kidney Donor Advocate Conference. We would like to thank Donor to Donor for this amazing opportunity to show our support and appreciation for living kidney donors. I cannot express enough thanks for your selfless act. Thank you, thank you, thank you. We at CareDx focus on transplantation. Transplantation is all what we do. Here on this slide, you not only see the transplant recipient, but also the transplant donor and the primary caregiver. We at CareDx focus on transplantation. Here you see our executive team coming to work every day, even during COVID-19, making sure that we continue to serve the transplant community. I want to share with you the many ways that CareDx is prolonging the life of those prisoners' kidney that you donated. At the minimum, we want to extend outcomes by 3 years, but our goal is to improve overall outcomes. We do that by focusing on immune modulation, compliance and adherence, and standardization and personalization. Allosure is our engine at CareDx. Allosure is less invasive than a biopsy and more accurate than serum creatinine. What is Allosure? Allosure measures donor-derived cell-free DNA in the blood. Increases Allosure levels means there is more donor organ injury occurring. When COVID-19 hit, we mobilized to launch RemoTrack, remote blood draws for transplant patients. Just last month, we launched the Allocare app for transplant patients as well, a very exciting new way to engage transplant patients. So there are many barriers and disincentives to living donations. CareDx also wants to ensure its employees could donate without risk of lost wages or losing their job. Back in 2018, we launched our LIDAR policy so that any CareDx employee can donate an organ or bone marrow without financial disincentives. On this side, you see that we are holding a proud coalition on Honor the Gift campaign. Some of you might be familiar with the Honor the Gift campaign, a joint coalition of transplant, donation, and kidney organizations who all support passage of the Immunobill, which would extend Medicare coverage for immune-suppressive medications beyond the current 36-month cap. We are happy to work with Donor to Donor and Honor the Gift campaign. Along with the other 32 organizations who have all come together to support this important legislation, we are driving change with the Immunobill. I once again wanted to express my heartfelt gratitude to all of you living donors and advocates of living donation. You have my promise that I will do everything I can do to extend the life of those donated kidneys. CareDx is 100% dedicated to the transplant ecosystem. Thank you for allowing the speaking platform. Thank you.